splint. "61-year-old male, Southwest NBC, was found to have this left lever deep fibular fracture. It was stress negative. It was put into a splint due to pain, ambulation. So he was made on. The 38-year-old female was called left distal radius on sideways fracture. There was nerve resting intact. Those are just equipment to which the 40-year-old male Southwest NBC with a left scapular fracture. He was given a sling for comfort. The 9-year-old male Southwest called the left forearm fracture. Some monkey bars. Was nerve resting impact both boots and the 60-year-old female as was fall to her left arm with a head on fracture. She was put into a sling. Heart release.
When female status was falling on the horse with a right sole to distal radius fracture. No resting intact. Those are just placed into that treatment splint. There's a 5-year-old male status was falling down the steps with a right forearm fracture. No resting intact. Those are just placed into the treatment splint. So an 11-year-old female status was softball slide with a left ankle triplane fracture. There's no vascular intact. Those are usually placed into a long way out cast. A 32-year-old male status with softball injury, with left shoulder dislocation, the first time dislocator, neurovascular intact. Those are used in downward practice. An 83-year-old male status post NBC, left ankle fracture, mid-shaft fibula with a non-displacement malleolus, non-weight bearing, placed into a short axis.
Morning. First patient, 65-year-old female, sent after fall, right distal radius fracture. Patient initially provisionally produced, placed in a splint, and patient was taken to the operating room with the right radius left frontal fixation. Next patient, an 18-year-old male, that had his left index finger on a slicing machine at work. Presented with a left fracture, next finger, and associated nail bed injury. The nail bed was repaired, business and bulky dressing. Next patient is a 79-year-old male presenting after the fall. His left hip and right side hip fracture. X-rays were initially negative, so the emergency department obtained MRI imaging. Rule out the fracture. The MRI did reveal non-displaced fracture. Patient was made effectively bearing with the walker. Next patient, 5-year-old male, presenting after the fall from monkey bars, the right tibial shaft fracture, neurovascular attack, was recent path. Good morning. First patient is a right head dominant female, the right distal radius shaft fracture. She's reduced, placed into a shakedown splint. Our next patient is the right head dominant 13-year-old male, left distal forearm fracture.
These both reduced as initially explained. Next, the right hand dominant 13-year-old male, left distal radius shaft fracture. These both reduced as initially explained. Next is an 8-year-old male assessed with small points bicycle on its left side, small finger, E1, solver head student fracture. It was reduced, body taped, next is a 27-year-old male, assessed with ground fall, it's right radial head fracture, neurovascular intact, with part of the brain function, swelling, pain. He was placed into a posterior splint, and followed for scheduling elective radiology.
What type is it?
It would be 2, it's not common even. So
What is it?
2 Mason, so it's displaced here in 2 millimeters. It's not common.
What was his motion?
So it's markedly limited because of swelling. And I'll be honest, I did not provide a hematoma block, so a true sense of the block.
What if you aspirate the hematoma and he has full motion? What's the treatment?
It's still operative for this patient.
Still what?
Operative for this patient.
And what type of procedure will you do?
I do RIF for the radial head, so 1 or 2 pieces.
So you're saying if he has full range of motion, this only will do well if you operate on it?
I would be surprised if he had full range of motion, but I would consider it at that time.
Did you guys get a CAT scan in the ER?
Not.
So this is a situation where getting a CT scan probably makes sense. It's hard to tell based on the X-rays, but if you can demonstrate that there's congruity of part of the articular surface with the shaft, that's good for planning, and it also probably bodes well for the potential of this healing. It's a lot higher chance of this going into non-union if you fix it, if it or AVN if everything is dissociated from the shaft.
Next patient is a 33-year-old male, was his hand in the bench from left next one the laceration, fracture, repaired central non-PC lines at central Next, a 29-year-old male who fell while during an altercation. It's the same as right metacarpal base fracture. He's placed into a ulnar better splint. Next is a 56-year-old male. Status was pressure at work. He said he got his foot wide and some sort of press. She at work and his right medial mallet fracture. He was placed into a short leg, short leg splint. Temporary out. Next is an 86-year-old female, hopefully injured, standing ground will fall 1 week prior to presentation. It was left as a plateau, severe this fracture. She's down again with slim for comfort and protected. Operative injuries. Next to the 40-year-old male, such person on DC, this C2 bilateral pars fracture. Fracture. He was placed into table traction. Next is a 54-year-old male, such person on DC, T11 chance, right, pars fracture. This patient was taken to the operating room for T9 to elbow. PSIF.
Can you go back to the MRI? Where, can you show me, and there's, maybe I'm just not seeing on my image, where the 3-column disruption would be? So is it near intact?
He was. He had a two beats of bonus, so that's the same.
Is that a pure bony injury?
Pardon?
Is that a pure bony injury?
Here. Hard to say.
Um,
Yeah. But I don't know if it's on. It's on.
So why do you need to fix a bony chance? Neuro intact.
Hard to tell if it's pure bone. You don't see it. Pardon? Gotcha. It's pretty common, unstable injury. Bone would be.
Can you speak into the microphone, or at least get closer to it?
Yeah, we didn't hear a single word you said, or at least I didn't.
Gotcha.
So the
That's three.
question, why do you need to fix a bony chance fracture, which will heal if it's neuro intact?
You know, his calculating T-leg score, he's 4, and so on the fence there with, and so at that point we decided that it'd probably be safer to give him some stabilization posteriorly.
So are you saying that we no longer chance fractures, which in the past always healed and in a brace, don't heal anymore if they're neuro intact?
I would never, no, I'm not saying that.
Well, I don't know. You know, it's one thing if it's a ligament goes through a ligamentous portion, or if it's not neuro intact. To tell us that it's unstable doesn't make any sense, because chance fractures didn't change since a decade or 2 decades or 3 decades ago.
Jomar, did you guys get wrist x-rays for that radial head fracture?
We had, you know, no, I did not change.
These bad radial head fractures where there's, you know, potential elbow instability, you really got to document wrist x-rays and document your examination there.
Gotcha.
Do you know why that is?
Yeah, he could have the injury at the PRJ, got problems with
What's the term for that? There's a pseudonym.
pardon me?
What's the term for that? It's got a name.
The SSC perceived like this movement.
Good.
Good morning. Patient is a 79-year-old female, status was fall, right hip air fracture. Fraction from rotation was being further greater stroke off, also taken for right hip DHS. Attempt was made at production with a conventional area now. The stroke fractures, difficult to starting points, so for DHS.
So how many part intertroch is that?
3.
Oh, looks 4, but so is it stable or unstable?
This would be unstable because of how far.
Why did you choose this implant?
What was that?
Why did you choose this implant versus, let's say, an intramedullary nail?
Oh, yes, so we attempted to do an intramedullary now, with due to greater growth between it was challenging at the starting point. So then we elected to open and with DHS.
So, okay, so you open,
Yes.
but the nail is, so if you have open, I'm assuming you open to help reduce it, correct?
Yeah. Yeah, so partially to help reduce it.
So you didn't open because you couldn't get the starting point.
The main problem was that the nail was displacing the trochanteric therapy piece. And so by going with the DHS, we were able to prevent that displacement of that greater trochanteric piece when we were passing the nail.
Okay, but is the graded trochanter important in the overall stability? Is that what you're trying to line up?
Not for the overall. It wouldn't be important for stability.
You are just like the stroke.
Yeah, we were displacing the trophy and the fracture as well.
Okay, so that means your starting point, yeah, it's difficult to get, or you were displacing when you were putting the nail down or when you were putting the wire down?
The nail.
Okay. All right, so then if you had it open, why not clamp it? Just a nail biomechanically is a better implant for these fractures. You can use a DHS, but biomechanically, nail is a better. So if you had it open, yeah, you're already using the open approach to reduce it. Why? I'm just confused why you wouldn't be able to get the nail in then.
Is there a clinical difference putting this in versus a nail in long-term studies on healing if you get it anatomic?
I don't think there's any clinical difference. I think
There is a clinical difference. Less blood loss has been found pretty commonly with nails, but it's now that it's open.
But it's already open.
It's already open, yes. But there's long term, assuming that yes, if the reduction is anatomic, long term they'll be essentially equivalent. Biomechanically, the nail is a both stronger and better implant for unstable intertrocks.
My comment
yeah.
would be, I think he did a great job reducing it. Why not put the screw a little further in to get better purchase, considering the comminution? Once it's open, it doesn't matter what you do. But why not put that screw a little further in? Is that not, I don't know what the distance is, but it seems on the lateral and the AP a little further than you'd want.
the screw probably could have been that's a little bit further, but it was within acceptable range.
What's the weight bearing status?
So we made them weight bearing is tolerated. We made them weight bearing is tolerated.
Okay.
Yeah. That's the one that.
Speak clearly and loudly.
Good morning.
Is it the slip? Just go. Come on, just project.
Good morning. First patient is a 10-year-old male who fell and sustained his left sulfur student's radius fracture. He was supposed to be placed into a surgical splint. Next patient is a 16-year-old male who fell from a dune buggy and had a left distal forearm fracture. He was also closed reduced and placed into a surgical splint. The next patient is an 84-year-old female who fell trying to close one of her windows. She's right-hand dominant, and she sustained a left distal radius fracture. She was closed reduced and placed into a sugar splint. Next patient is a 12-year-old female who fell from the bike at this right non-displaced radial head fracture, and she's placed into a sling. Similarly, this is a 36-year-old male who fell and had sustained this right non-displaced radial head fracture and was also placed into a sling. Next patient is an 87-year-old female who fell from standing. She has this left LC1 pelvis fracture. She is severely affected, malnourished. She walks very nimbly at baseline, but she was made weight bearing as tolerated and was placed on DBT prophylaxis. Next patient is a 25-year-old male who was going up for a layup and fell, probably hyperextended his knee and sustained a right anterior knee dislocation. His ABIs post-correction were serially examined, and they were between 1.0 and 1.1 overnight. Not included, sorry, I actually got his MRI this morning, has ACL, PCL, and PLC. Next patient is a 52-year-old male who tripped going down the stairs and sustained this right open small toe proximal phalanx fracture with a laceration dorsally. He was given tetanus, ANSEP, IV, preliminarily washed out in the emergency department, reduced, and buddy taped and placed into a bulky dressing with vertical shoe and left on antibiotics slowly. The next patient is a 46-year-old female who was involved in the MBC a few months ago, and originally went to an outside hospital where her x-rays were read as normal. She followed up in the office a few months later for persistent pain. CT imaging was done, which showed a comminuted medial cuneiform and middle cuneiform fracture with some subluxation of the second metatarsal with a mid-strength variant. She was taken to the operating room for a right navicular cuneiform arthrodesis and tarsometatarsal with a reduction in total fixation. The next patient is a little complicated. He was a polytrauma. I'll just be presenting. We'll be presenting again later, but he had a right open talar neck fracture extrusion that was 100% extruded from his body. It was urgently reduced and washed out in the trauma bay. And CAT scan imaging was obtained showing this talar neck fracture. He initially underwent ankle irrigation debridement and external fixation. And a few days later underwent IND and open direction internal fixation of the talus. He was also placed again into an external fixator just due to instability of his ankle. The next patient is a 36-year-old male who tripped and fell and had this left non-displaced base of the fifth metatarsal fracture that looks to be in zone 2. He was placed into a posterior splint and may not repair.
Is that talus fracture anatomically reduced?
It is overall, yes. He definitely has a piece missing, like medially, where it's just very comminuted. And we had to excise some fragments just because they were just like loosely, nothing was really keeping them there. But overall, we were very satisfied with our overall infection.
What is the expectation for healing of this and it undergoing AVN or not undergoing AVN?
Oh, it's gonna be terrible. He's like a 90 to 100% chance of going on to AVN, which we had this long, extensive conversation with him and his family about. He's really young. And so it's worth a shot just to at least, try fixing it, see what happens, but ultimately he's probably gonna need to undergo, arthrodesis in his future.
There's some nice wrist reductions. Good job.
Morning. First patient's a 57-year-old female who fell, was found down next to her bicycle, trying to remember what happened, and had this right distal clavicle fracture. Treated normally during the sling.
What's the union rate for distal clavicle fractures?
It's like 85%, 90%,
Well, then what's the union rate for midshaft fractures?
like 95.
I didn't hear you there. What was that?
Like 95%.
So it's 85% for midshaft clavicle fractures. So is the union rate higher or lower for distal clavicle fractures?
Lower.
Correct. A lot lower.
Todd, why is that?
Not sure.
You know,
This is an 85-year-old female, status post-fall, with a left scapular fracture. It's unclear exactly how long it was going on for. She has dementia and has a repetitive history of falls. She had a previous proximal humerus fracture, which had healed. Made weight variance tolerated for sling. This is a 75-year-old female, status post-fall, with a left humeral shaft fracture. Nerve actually intact. It's placed into the coaptation splints. A 44-year-old female with cholangiocarcinoma with metastases to her spine, pelvis, left femur, and brain, who sustained a fall down a few steps and has this pathologic left distal femur fracture, as well as a pending fracture in the femoral neck due to an lesion there. She was initially placed into side slab splints, taken for a CT. MRI. She was then taken for a left femur, antegrade intramedullary nail, and distal femur ORF. Maybe weight variance tolerated.
Just to follow up on clavicle fractures, I think you're referring to displaced clavicle fractures, because I think the non-displaced clavicle fractures are close to 100% bony union. So I don't know what article you were quoting there.
Displaced.
First patient is a 4-year-old male who fell and suffered cheese from a humerus fracture. He was placed in a posterior splint emergency room and then taken to the OR the next day for a closed reduction for cutaneous spinning. The next is a 36-year-old female who fell down the stairs and sustained this open trimal ankle fracture. She was closed, reduced in the emergency room, given ANSA, and then was taken to the operating room for an IND and ankle ORIF. This is a 48-year-old female who was chasing after the dog when she fell in her driveway, sustained this left distal radius fracture. She was closed, reduced, placed in sugar on splint, and she'll follow up for some surgical planning. This is a 19-year-old male who was avoiding getting hit by a car when he twisted his ankle, sustained this bilateral equivalent ankle fracture dislocation. He was closed, reduced, placed in Charlotte Bayo.
If that wrist fracture healed the way it was, would that be acceptable or not?
It's a little short, I think. The rule in terms of roller tilt, it's about neutral. It's her non-dominant hand, so you could argue it would be fine, but that roller, ulnar corner, that vertical corner is off, and there's a lot of intra-articular involvement. So given that she's young, I think operative fixation would be a better choice for her.
No, I'm asking if it healed like that, is that, I realize that it may not stay there. Is that articular piece acceptable or unacceptable?
I guess it's technically acceptable.
Okay.
This is a 6-year-old male who fell. He's seen at an outside hospital and told to follow up with ortho so he can hear. He had a both bone forearm fracture. He was closed, reduced, placed in a sugar tonic splint. This is a 59-year-old male who was in a motorcycle accident. He was found to have these left clavicle and scapular fractures, as well as some rib fractures. He was given a sling and a follow-up operation.
First, this 10-year-old girl, that's the fall in basketball, right, small finger, one fracture. Big dropping for adjustment. Next patient, 11-year-old girl, that's the fall gymnastics, that was placed right in the fracture. She initially sprinted, and outside hospital came to the office to follow. She was with a high level of gymnast and especially had that operative not for management. And she elected with her parents and the operative fixation of the fracture. Next page, 11-year-old boy, second fall. Fracture, nervous impact, safety operating.
Hey, Dan, when you fixed that medial epicondyle, did you stress the elbow in the OR to see if it opened to valgus?
We took through a range of motion, but we didn't stress the valgus.
I'm sorry, say that again.
We took it through a range of motion, but we did not specifically stress the valgus.
Did you look, I'm just curious anatomically, do you think the UCL is attached onto that piece, or do you think that's just the common tendon origin?
I think it's the tendon origin.
I'm not hearing you so good.
I think it's the tendon origin.
Morning. Patient's a 53-year-old male who presented as a trauma after a motorcycle crash with left vocal opening, type 3 rub mechanism, distal radius fracture. Also right, open forearm fracture, again, small focal, type 3 rub mechanism. And right, fourth metatarsal neck, fifth metatarsal base fracture. He was initially irrigated and splinted in the emergency room. Started developing painful paresthesias of his left hand, side with distal radius fracture. He also had bilateral mandible fractures. He was taken up urgently to the operating room for a distal radius fracture, internal fixation and carpal tunnel release. Also a local forearm fracture, fixation, and full reduction and percutaneous pinning of this face.
And where you typically place the plate in the distal radius? Why so radial?
Well, it was a difficult, sorry. It was difficult to get our reduction, so we spent a good amount of time trying to obtain this reduction. We ended up putting the screws in distally first, and then kind of rotating the fragment to kind of lever that up to get our radial inclination height back. We did see that the plate was a little bit radial, but at that point, we were satisfied with our reduction, inclination and height, lower use of joint surfaces good. So we decided not to try and move the plate over. It's not as great an X-ray, but in terms of the plate position, but the reduction is good.
I mean, the reduction looks awesome. So as long as it doesn't shift, you're good. The plate doesn't look prominent above the lip. You know, it's nearby, but I don't think it's, you know, above the lip. So
Does it ever hit the brachioradialis if it's too radial? I'm just curious.
I think you worry more about the first dorsal compartment if the screws are out up top. That's certainly a possibility. And these screws look like they're in the bone. I guess the plate, you know, the plate is probably volar to where those tendons run. So, but certainly it's something you got to think about.
Well, they probably released the brachioradialis to try and reduce this. The only thing, I agree, the reduction's perfect. This is when you would splint or cast, since you only have one screw in that ulnar facet. But I wouldn't have moved the plate, and I think it's going to be fine as long as you immobilize it a little, make sure it heals.
These people with acute carpal tunnel syndrome get really stiff. So it's ideal to try to get them moving a little bit quicker, but you obviously got to get the bone to heal. So it's a tough problem.
Good morning. First patient was an 19-year-old male, a gunshot wound to his right arm through the shaft. The following morning for a right ulnar IND, ORIF. Next is
What was the neurovascular exam?
he was neurovascularly intact.
Did you compress with that plate?
We did not compress that plate. There was quite a bit of comminution there, so it was more of a.
So you're bridging that fracture?
Yes.
So what's the long-term plan as far as getting that to heal?
So if you were to go into non-union, you could always go back and try to revise it with the bone graft, like press through whatever residual.
So are you planning to bone graft that at 6 weeks or 4 weeks or?
You're not planning to bone graft this at 6 weeks. You're gonna follow him with with radiographs.
Is there any bony contact there?
There is some bony contact.
What, 10%, 20%, 50%?
I would probably say 20%.
So with 20% bony contact, you think that's going to heal?
I think he's got a try to do it.
But well, what's the natural history when you only have 20% contact on a forearm bone?
that you would go on to at least the late union, probably non-union.
So why is this something you wouldn't just ahead of time prepare to bone graft?
Yeah, sorry. It's amateur. Next, 20-year-old male, he fell playing soccer with his left forearm fracture. He's provisionally splinted. Taken the next day for a forearm ORIF. Next is a 30-year-old male involved in NBC at an outside hospital with a right hip fracture dislocation, posterior wall acetabular fracture. CAT scan was obtained at the outside hospital during the dislocation. Posterior wall fracture. He was taken OR for a posterior wall ORIF. Next, a 39-year-old male with a past memory history of uncontrolled diabetes, factor V vitamin deficiency, with previous CVA and residual left-sided weakness, minimal motor in his left upper extremity. He sustained a tripping fall down 2 or 3 steps with his left intertrochanteric fracture and left distal humerus fracture. He was taken over for a left femur IM inside the prophylaxis entire bone just due to his history of frequent falls and poor bone quality. And then he also underwent left distal humerus fracture, which was severely comminuted, and underwent a left distal humerus ORIF. Next is an 89-year-old female sustained a triple fall with a left intertrochanteric hip fracture. Taking the OR for left hip IM. Next is a 92-year-old female who sustained a fall down 4 steps. His right pelvis impacted from neck fracture, right humerus fracture. He was taken to the OR for right hip annually screws and this humerus fracture. Originally splinted and then taken for a same time the humerus ORIF. Next, we have a 39-year-old male who does NBC with his left radial shaft fracture. Taking the OR for radial shaft IM now.
Did that go into the joint?
We did a CAT scan that showed that that fracture line did extend proximally, but did not actually go into the joint. But we were aware of that beforehand. Next is a 35-year-old gentleman who's involved in NBC when he driving a box truck rear into the truck, came in with this left segmental femur femoral shaft fracture, a traumatic PKA, as well as a distal crank fracture. This is the only shot from the CAT scan image. He was taken immediately to the OR for a washout of his PKA, his amputation, as well as provisional fixation, X6 of his femoral shaft fracture, and then close reduction of his spine. He was taken about a week later after he was stabilized for a femoral shaft IM nail. He was taken for a list frame. Fracture you can see on the one snapshot from the CAT scan, this frame is dislocated, initially closed reduction. Or CAT scan was obtained after he was reduced. Better going fracture pattern, taken for a frank ORIF, and continuing this parcel. And then finally, he was taken after several washouts for a revision below knee amputation. Next is a 26-year-old male involved in a motorcycle versus car. His right femoral shaft fracture, a left tibial plateau fracture, left femoral shaft fracture, left distal femoral condyle, MCL avulsion, and a right talus fracture exclusion. Talus was just previously done earlier today. This was the tibial plateau, which was originally X-fixed on day 0. It was taken later that week for tibial plateau ORF and MCL, neoperoneal condyle, bulging ORF. The femoral shaft fracture was treated the same day it came in. A femoral nail. Ulnar shaft fracture was treated the same day as his plateau. Shaft fracture originally splinted, taken for an ulna ORF.
Did you think about using intramedullary fixation for the ulna?
We had not discussed intramedullary fixation, that would also be an option. They're fairly transferred. The more proximal of the fractures in the ulna was actually a little bit comminuted. That's why we had these mini track plates, try to catch some of the combination. And we bridged with and pressed with the track plates.
And students, if you are presenting this week, grand rounds, send Michelle your topic, objectives, and a headshot of yourself. Thank you.
Thank you.